I am Hillary Deskins. I am a nurse navigator consultant with Leo Cancer Care. Thank you so much for joining this webinar. I think this is going to be very informative. We have two very special ladies that are going to be presenting today, and I want to tell you a little bit about each one. The first one is Tina DeStephanis Griffiths. She is a lung program administrator and lung navigator at TriHealth Cancer Institute in Cincinnati, Ohio. She completed her undergraduate in nursing at Christ Hospital School of Nursing and Xavier University, and then received her master's in nursing informatics at the University of Maryland, which was highly beneficial during the building of TriHealth screening program software. She is oncology certified, and in 2018, she joined TriHealth Cancer Institute and has been instrumental in leading the expansion of the lung cancer screening program from prevention to early detection. So glad to have Tina on board. The other person that's going to be presenting today is a nurse practitioner, Nancy Pace. Nancy graduated from the University of Cincinnati with her bachelor's and master's degrees in nursing. In 2010, she transitioned into oncology and has remained in this field as an infusion nurse, a lung screening navigator, and a nurse practitioner, implementing a lung cancer screening program for another community-based hospital in the Cincinnati area. In the navigation role, she fostered partnerships with primary care offices to build the program while providing education on lung cancer screening and the importance of a lung cancer screening program. In 2018, she joined TriHealth as a nurse practitioner for its 5 lung cancer screening clinics. So a little bit of just one little thing I need to tell you before we get started. Everyone will be muted during the webinar. However, to submit a question, please check the chat button at the bottom of your screen and direct your question to host and panelists. We'll address all questions during the last 15 minutes of the webinar. Also, I'd like to give a shout out to our behind the scenes marketing guru, Fiona Redford, who is across the pond over in the UK. She is the head of marketing for Leo Cancer Care, and she is the one responsible for making this webinar run smoothly and effectively. Thank you, Fiona. So Tina and Nancy, I'll now hand it over to you. The floor is yours.
Thank you.
Great. Thank you so much, Hillary. That was so nice. It's very generous. We appreciate it. Good afternoon. My name is Tina. I'm a nurse navigator with TriHealth Cancer Institute. I'd like to introduce my colleague, Nancy Page. She is a nurse practitioner with our lung screening clinic. Thank you so much for giving us this opportunity to talk today on behalf of our program, the successes of our program. We're very excited to share our information. Our focus is early detection and prevention, and our goal is to optimize screening and patient outcomes. We want to start off first by giving you a little bit of information about TriHealth. TriHealth is located in Cincinnati, Ohio. We have 7 hospitals and an emergency in the area. We have 9 imaging locations. We have more than 12,000 team members, including over 650 employed physicians and nearly 1,500 affiliated medical providers. We are one of the region's largest healthcare systems and the 3rd largest employer in the city. Since we're not going to be focusing so much today on how we build our program, we're going to talk more about the strategic growth of the program. We first want to start out by just giving you a brief summary about our program, how it got started. So TriHealth Lung Program, TriHealth was actually screening patients as far back as 2014. So the time frame between 2014 and 2017, we screened around 1,220 patients. So at that time, I think that's when lung leadership decided, looking at the numbers, looking at the patients being diagnosed, what can we do for our community? How can we capture patients earlier at stage 1s and stage 2s? So at that time, they decided in 2018, they were going to start a lung screening program, and that's when they hired all of us. Our lung leadership team is a group of specialists. It's comprised of representative or stakeholders. They're all relevant to the program. It includes level administrators equipped with decision-making ability. I will say they are the key to our success, and everyone asks us all the time, how come your program is doing so well? I think without the support of leadership, we would have struggled. So they are our voice and they are the success of our program. Our staff is definitely the systems engine and currently demands considerable time as lung screening moves towards a growth equivalent to mammography. Our staff is a nurse practitioner, 2 lung navigators, and we share 1 medical assistant with another part of the program. They manage the education, recruitment, both the provider and the community side. They oversee the lung screening clinic and they manage the data associated with the program efforts. We are a hybrid program, and people ask me that as well. What do you mean by hybrid? We are not solely a centralized program or a decentralized program. We basically, physicians have the option. They can complete a shared decision-making visit and order a screening, or they have the option referring to one of our 5 lung screening clinics. As far as tracking, Epic lung screening modules, what we use for our tracking. We looked at different softwares and we felt since we already had Epic in place, we were just going to stay with the Epic program, and that seems to be working fine for us right now. Data collection, reporting dashboard. We get a lot of information, and that information with the help of our information and innovation specialist within our Cancer Institute, they've created dashboards for us to report all of our data. How are we going to, so in order for our screening program to be a center of excellence, we needed to build this comprehensive lung program. So in addition to our lung screening program, we have 3 lung nodule clinics. We have a review board, which includes a lung multidisciplinary clinic and a lung tumor board. We have a lung screening review panel. We also follow incidental tracking under the comprehensive lung program, and we offer smoking cessation to patients at 3 different locations. So we are a center of excellence. We are our director, lung screening and lung nodule director, program director is Dr. Craig Eisentraut. He is the head of pulmonology. He has been very instrumental, along with our cardiothoracic surgeon and our oncologist, as part of our program. So what do we do with all this information? People say, how do you market? What do you do with it? Well, we look at it as education and outreach. The first thing we need to do is educate within our organization. You know, we think about, wow, we have 12,000 people. That is 12,000 voices that we have. Those team members, they interact with patients on a daily basis, whether it be in an office, on the phone, out in the community, volunteering for one of our many departments within TriHealth. They are a voice for us, so we educate them first. Next is a branding. You know, everyone these days has a brand. You know, you think about that. I joked and I say, you know, I'm driving down the highway and I'm looking for somewhere to go and find some place to eat. They don't have the words anymore. They just have the brands, the yellow arches and the kernel and all that. So our brandings are the blue lungs, and we use that on all of our websites, our flyers, and our posters. We extend our outreach to include out the community. So we are involved with we partner with corporate health. So we are involved with large corporations. We, through television, social media, billboards, and we partner with our local Cincinnati Reds team. We're a sponsor for them. So we're at multiple events there as well. So right now I'm going to hand this off to Nancy, and she's going to talk to you more about the strategic growth of the program. Thank you so much for listening.
Thank you, Tina, for the information on TriHealth and for the overview of our program. And I do want to welcome everyone to the webinar today. So over the next few slides, I'd like to share with you what we feel has contributed to the growth of our lung screening program here at TriHealth. On the graph, you will see from 2019 through 2021, we have had a 317% increase in our annual follow-ups. And we contribute our success to the following factors. Number one, we have established workflow processes. So for example, we have processes in place for how we handle LRAD 1, 2, 3, and 4 results, how we get patients scheduled, whether that be in our clinic or for follow-up. And we also have standardized templates that we use when we communicate with our physicians. We felt having these processes in place was essential for the program to run smoothly. Because we're a small team, there are 3 of us, there are 2 navigators and myself. Having these processes allows us to be more efficient because we are all following the same process. This is very beneficial because if one of us is out, it does not hinder the patient's care. We can go into our dashboard, we can see where that patient is at in the process of their care, and we can pick up from there. Having these workflows also allows us to analyze what we are doing and improve the process. To have a 317% increase in annual follow-up takes manpower. We are a very hands-on group. We call and we get our patients scheduled for their annual lung screens. We generate reminder letters and MyChart messages on all those we cannot reach by phone. And we also place orders on behalf of the primary care physicians. And what I mean by this is when we go through our dashboard, and if we see somebody is due for an annual lung cancer screening and they do not have an order, we first of all make sure that they meet the criteria, and then we will place the order on behalf of that primary care physician. As your program grows, you are going to need to have a tracking system that works for you so that you do not lose your patients to follow-up. We use the lung screening module in Epic. In 2019, when our clinics opened, we investigated the specialized software that was available for lung cancer screening. We also attempted to develop an Excel spreadsheet. We did find that this was too time-consuming to try to use, and it did not meet our needs. So finally, our lung team decided that we were going to use Epic. For those of you who does use Epic, you know that it creates a lung screening dashboard, which allows you to run different reports to manage follow-ups, print reminder letters, results letters, and receive daily results. At TriHealth, our team does break up the management of the dashboard. So the study's missing data report, which shows you the daily new results, is used by all of us. One navigator handles the LRAD 3 results, and the other handles the LRAD 4 results. The LRAD 1 and 2s, again, are managed by us all. We just recently changed our process regarding the LRAD 4 results. LRADs 4A and B are now reviewed weekly by our lung screening review panel, and our navigator plays a critical role in this process. When an LRAD 4A or B comes in, she does send a message to the primary care, informing them that the results will be reviewed by the lung screening review panel. She then compiles a list of all of the LRAD 4As and Bs. This is then presented to the panel to get their recommendations. Once we have the recommendations, the navigator then contacts the patient and arranges the follow-up, unless the ordering physician would decide that they want to handle this on their own. The LRAD 4Xs are done in real time, and we usually contact our patients within 24 hours. Next slide, please. We also contribute to our strategic growth, our lung cancer screening clinic. Our clinic did open in the fourth quarter of 2019, and we have had over 2,000 referrals. As Tina mentioned earlier, we have a hybrid program, which again is a mixture of a decentralized and a centralized program. We do have standard processes developed in getting patients scheduled in our clinic, so any navigator can perform this task. Our clinic visits are around 30 minutes. During the visit, we conduct a shared decision-making visit. We do a risk assessment for lung cancer screening, and we talk about smoking cessation. We do follow a patient-centered model of care in our clinic. We do believe this allows the patient to play an active role in their health care. Also, by having the clinic, it gives us time to educate our patients. There are 2 common questions that I frequently get from patients that come in. Number 1 is, I feel good and I don't know why my doctor wants me to do this. And number two, why do I need to continue screening if the test comes out okay? By having the time to educate our patients, we can clear up any misconceptions, and it does promote patient buy-in, and they want to continue with the annual screening or the baseline screening. Our clinic also offers convenience. We have 5 clinics in various neighborhoods. We have 4 within the Cincinnati area, and we have 1 located in Oxford, Ohio, and we are planning on opening another clinic in 2023. The clinic does mail welcome letters to the patients with their appointment information, and the patients also get a reminder call a few days prior to the appointment. Next slide, please. So even though we have had a 317% in growth in our annual follow-ups, we still have challenges. As we continue to grow, staffing again will be a challenge. As you can see from the graph, our baseline screenings have been rather flat. We need to look at how we can improve this. Why are the physicians not ordering? Is it due to a time constraint? Is it difficulty in conducting the shared decision-making visit? Why are physicians not referring to our lung cancer screening clinic? And also, why are patients not scheduling? As we indicated, we are a hybrid program. So when patients do see their primary care, they can also order the lung cancer screening. And we have some software where we can go in and we can see how many lung cancer screenings are ordered versus how many people have actually scheduled them. So we really need to understand why the patients are not scheduling. Is it something that they just didn't have time to get all their questions answered when they visited their PCP? Is it a fear of a cancer diagnosis or with the stigma related to smoking? And was there a shared decision visit completed? I just recently looked at an article in Cancer Medicine magazine. It was dated February of this year. And the title of the article was The Impact of a Shared Decision-Making Visit Process in the Decision to do a Lung Cancer Screening. And basically the article indicates that if a thorough shared decision-making process visit is actually associated with better outcomes among patients to be screened and to undergo the process again. Marketing is an important component to our strategic growth. And in 2021, we had a change in our infrastructure. So we need to make sure that we need to improve our consistency in marketing lung cancer screening and build brand recognition within our community. Next slide, please. So how can we continue to grow and improve our screening numbers? As you'll see from the information on the left, from 2018 through 2021, there were over 40,000 patients possibly eligible for lung cancer screening, and we only screened a little over 1,000 of them. So we really need to look at how we can improve this. We are planning on to continue educating our primary care physicians, but this time when we go out and visit them, we are wanting to make the discussion more personal to them, and we want to share some data that we are actually able to retrieve. We are able to run a report on how many physicians have patients who are smokers and how many lung screens have they ordered. So on the right, you can see from the diagram, we'll call this physician A. He had 105 patients who are current smokers and potentially eligible for lung cancer screening, but only 3 received a low-dose CT. Next slide, please. We also need to continue to evaluate our program during our quarterly lung leadership meetings. We have a lung leadership group. The group is composed of pulmonologists, a thoracic surgeon, medical oncology, radiation oncology, a radiologist, a nursing and IT, marketing, and social work. So during these quarterly meetings, this gives us a chance as a group to come in and to look at our data, to look at the strengths and the weaknesses of the program and see where we can improve. We also are going to investigate possibly changing from a hybrid program to promote a centralized program. There is a lot of data that supports centralized lung screening programs. There was just some emerging data that suggests that annual adherence to lung cancer screening is poor, and a centralized approach to screening improves adherence. Those in a centralized program also are more likely to meet the eligibility criteria, and again, are more likely to return for annual screening. We also are looking to develop a screening protocol for our primary care physicians. We know that in order for this to be successful, we need to engage and work with the primary care to develop this policy. We feel that if we work as a team, we'll have more buy-in from the PCP to follow and support the policy. And lastly, we need to continue our community outreach. We need to utilize the communication platforms such as community health fairs, social media, educational brochures, and TV. We are also looking to use MyChart as a vehicle to get lung cancer screening information out to patients who may qualify. Next slide, please. So if you should have any questions, please feel free to reach out to either Tina or myself. Our emails are listed on the slide. This actually concludes my part of the presentation, and we will now open it up to any questions. Thank you very much.
Oh, Nancy and Tina, thank you so much. That was wonderful. My head was swimming and I'd heard it before, but I was like, oh my gosh, there's so much information going around. So we do have some questions that came in. I'm kind of excited about this. So the first one is, you say educating primary care physicians is a hot topic, is a key point of it. Do you have a physician champion as, to help bridge the gap with your primary cares, but also to bridge that gap with administration?
So that is an awesome, great question. TriHealth has an excellent lung program that is committed to improving lung cancer survival. We are fortunate to have a lung leadership team that supports lung cancer screening. So again, as Tina mentioned, Dr. Craig Eisentraut, who is a pulmonologist, he is the director of our lung cancer screening program. But along with Dr. Eisentraut, we have Dr. Robert Adams, who is a cardiothoracic surgeon, and Dr. Andrew Parchman, who is a medical oncologist. These guys make up our physician champions for our program. These physicians have presented to many primary care offices and administration on the importance of screening and have been instrumental in the development of our program. I don't think we would be where we are today without them.
Wow. Okay. Okay. And here's a question, and I'm so glad this was asked because this is a question I kind of wanted to know myself. How did you get administration to give you the support you needed? Was there a comprehensive ROI that you used, or how did you, because so many times administration, and I mean, I had this in my experience, the administration was kind of like at the other end of the spectrum. They didn't have a clue. We barely knew that we existed. So how did you all get administration to, support you?
So, yes, that's a question that we get often as well. We're fortunate, and I should say we're blessed, that administration was already in place. The lung leadership team that Nancy had mentioned, they were already in place before we even came on board. So it was just a matter of having all of us come in and educate them on what we need to do. They totally supported us, especially we have our chief of a VP of our clinical service line. He was incredible and very supportive of us. So I think after they pulled all the data, looking at the stats of the patients, why are our patients being staged at late? Why are they being diagnosed at later stages with lungs? We needed to do something for the patient. So I think they knew that it was time. Yeah.
Okay, that makes total sense. So the lung leadership meeting, is there anyone from administration? Nancy, you read off a list of people that were involved. Is administration involved in that lung leadership meeting?
Yes, they are involved in that meeting.
Okay.
So that was the clinical. Yes, that was the VP of clinical service lines, Mark Whitty. He oversees our Cancer Institute and also the Heart Institute as well. So that's a great combination.
Okay, That makes sense. So you all, I'm assuming you report numbers to this lung cancer meeting, so they kind of know what's going on and when. So that's how administration would know that what's going on, like how many cancers you found, how many surgeries came about from those cancers, and that kind of stuff.
Yeah, so we have quarterly lung leadership meetings. We do report all the data to them, exactly what you said. How many patients did we screen? How many patients were diagnosed? So for us, on an average, starting from 2014 till now, we're finding 1 out of every 55 patients are being diagnosed with a cancer. So, using those numbers, we report all of that. And with staging, we're finding that the staging is improving as well. We started out where the stages were 60% at later stages. And then now that the program, we're starting to see it shift a little bit more. And it's getting better. I think with the COVID and everything, patients weren't coming in as much to get their screenings, but yeah, I think it's gotten better.
Okay, here's a question from another question from the outside. Was the data on the provider's number of eligible patients and the number of lung cancer screenings that they had ordered, was that all pulled from Epic? You had that, like that one guy, Dr. A, that had 105.
Right.
Are you able to pull all that from Epic?
Right. We have an information innovation specialist, and he is actually able to pull this data for us from Epic.
Okay.
Yeah.
Okay. Now here's another, and this is a long question. This is from Megan. I manage a centralized program that manages over 11,000 low-dose CTs annual and baseline annually. We are evaluating the Epic dashboard, but are uncertain of its ability to keep up with our volume of patients. Do you have any advice? Do you feel that Epic dashboard can manage that volume?
I feel that the Epic dashboard can, because as of right now, I looked at our stats today, we have 14,500 patients that have been screened. It's not so much Epic. I think you need the manpower. You need, like we have a lot of our nurse navigators and Nancy, you need the manpower to do it. So the technology's there. It's just a matter of, having the manpower to do that.
Okay.
Yeah. I definitely agree with that.
Okay.
Manpower is key.
Okay. And then here's a question from Kelly. Are your patients seen in person, or do you use telehealth for clinics? Is one more efficient for the patient, or I guess either or more efficient for the patient?
Kelly, that's a great question. Right now, our clinic, we see patients in person. When COVID came out, we actually did a few of the virtual meetings or virtual appointments, but since the numbers are dropping in our area, and we have basically we see them in the clinic. We haven't done a lot of virtual appointments.
Okay.
So, to add to that as well, one thing about our clinic is that when Nancy sees them, as soon they get their scan right away, and they call the results as soon as they get the results by the end of the day or within 24 hours. So it helps for the patients to come in and get their scan. It's better for them to track them.
Excellent. Okay, that makes total sense to me. Somebody else asked, how do you secure the monies that you needed for all that branding? Because that has to be pretty expensive.
Well, because we were a new program that was already built into the budget, it came through the Cancer Institute. So, not like we were wasting money and trying to spend all this money, but it was already built in. They knew what we needed, and we were just supported.
Okay, that makes sense. And then another question is, and Nancy, you touched on this a little bit. If one of your patients has or develops a lung cancer, what is your plan for passing them off to oncology navigators? Do you still continue to follow them? And along those same lines, who presents these patients at your tumor board?
So if a patient has a lung cancer screening and the result is an LRAD 4A or B, again, that case is presented to that weekly lung screening review panel.
Mhm.
If it's a 4X, the case is reviewed in real time. So what happens is our nurse navigator gathers the medical and imaging history on the patient. She compiles a list that's reviewed by the panel. After the team is reviewed, the follow-up recommendations are given, and the nurse navigator then informs the PCP, and she calls the patient again and arranges any testing that's needed. And if a cancer diagnosis is made, that patient is then transitioned to our thoracic oncology specialty navigator. And this navigator then follows the patient from diagnosis through survival.
Okay. So you all don't continue to follow them then if they're just passed off. Okay, well, that makes total sense.
Right.
There's no way you could continue that. You would be so crazy busy. Somebody else is asking, have you noticed since the beginning of your program, if your stage 4 lung cancers, the number of stage 4 lung cancers have started decreasing and the number of stage 1 lung cancers have started increasing?
Absolutely. Absolutely. We're at a difference. We're starting to see more of like the 60s percent, greater than 60% shift. We're starting to see it more this year, last year and this year. I think, again, because of COVID, people were delaying being seen or delaying getting their scans. So that may have created that later stage for them. But I'm starting to see it more now.
Okay. Okay, that makes sense. And then the last question that I've got from the audience is through Epic, we use Cerner. So how did you find the number of current and former smokers for your facility? Was that in Epic?
Go ahead, Nancy.
I was going to say, yeah, that ultimately was pulled out of Epic. Again, that was that information innovation specialist that we had. He was able to pull that from Epic.
Okay.
On current and former smokers.
Okay. Okay. So that was the end of our questions. And I think we can close out early and give some people back some time. Thank you again so much. I do want to tell everybody that if you registered for this webinar, even if you weren't able to attend, you will be getting a copy of the slides within a week, along with both Nancy and Tina's contact information for any further questions. For those of you who joined us, thank you for your time. Tina, Nancy, oh my gosh, and Fiona behind the scenes. Thank you, and have a great rest of your week, everybody. So long.
Thank you so much.
Bye-bye.
Bye-bye. Have a good day.
Mhm.